Hello, everybody. Welcome to the Fig Geek Show. It's been a while since I recorded a podcast, and I wanted to start off this episode with Lyle McDonald, who's been a guest on our show before as well. And I've always looked up to Lyle in terms of information, research, his opinions, and whatever content he puts out on his website and his Facebook page. His Instagram is also active, but it's quite hilarious.
A little bit. Not
yes. So thank you so much, Lyle, for joining us today.
Thank you for having me.
And today's topic is something that is so rampant around the world. It is PCOS, polycystic ovarian syndrome. And when I put up this story on my Instagram, I got so many questions from mainly females and also from some males who are fitness professionals and who want to understand this, more in depth. So I did not think of anybody else except for you in terms of like female physiology. That's why I invited you to talk on this topic.
I appreciate it, and you're not wrong. Polycystic ovary syndrome is, I believe it's the most common reproductive disorder in women, depending on the study and what criteria you use. We'll talk about that a little bit. You'll see numbers anywhere from 5 to 20%. And I've read so many studies or so many papers, and I kid you not, I've never come across the same two numbers given. They'll be like, some will be 5 to 13, 7 to 9, but it's in that range. And some of it depends on the diagnosis. It causes a tremendous number of problems, and we'll talk about that. But of even almost a bigger issue, or as big of an issue, it is incredibly either underdiagnosed or misdiagnosed. Many women have it for years, and they have problems and they have issues, and nobody can tell them why. Because for some reason, and I don't know what it is, this diagnosis of polycystic ovary syndrome just frequently isn't made. And part of it, and again, we'll talk about this when we get to the criteria and the diagnostic criteria, is you have to eliminate other things first. It's almost a diagnosis of exclusion. You have to make sure it's not these 5 or 6 other things. And even then, I've heard of women say, they suffered for years, for a decade or more, and didn't get a diagnosis, and finally got one and were able to get proper treatment, and it was life-changing. So I don't know why that is still really the case in 2021, but it's commonly missed, and it is extremely common.
I agree with you, because even in India, I'm pretty sure this has been around for a while, but the awareness has just started building up over the past maybe a decade or so. And out of, like, say, example, 10 female clients I train, 8 have been diagnosed with PCOS. 8 to 7 to 8 easily, 70%. 80%.
Wow,
yeah.
That's huge. Okay.
Yeah, and especially in cities like Mumbai and Delhi, and big cities where the lifestyles are a little messed up. That's where I've seen that this is more common. But to begin with, what is PCOS, and is there any difference between PCOS and PCOD?
So I'll be honest, I had not even heard of PCOD, polycystic ovary disease, until you emailed me. Oh. And so I did some looking online, and I found very little research. And what I did find was very, very old. I mean, 30 or 40 years old. The articles I found either said they were the same thing. I did find a number of articles that made this very slight distinction between the two. And what I found interesting, and maybe you can speak to this, every single one of them was from an Indian news or medical source. So I genuinely wonder if this is a distinction that is made in India that is not, for whatever reason. And when I looked, the distinction that was being made, it was so subtle and so small, and kind of ended up at the same place. And remind me when I talk about, what the next question, we talk about the criteria for PCOS diagnostically. And as I read it, it seemed like it was such a small distinction that I don't know that in a practical sense that it matters. But I think that'll make more sense when we address the second question. But the second question you wanted to ask.
Yes. So what are different kinds of polycystic ovarian syndromes? Okay. Are there any types?
Yes, and this is something, so sort of to go back just for brief history. So if you look through the history of the world, you will find folks writing, we're talking Socrates, philosophers, about women, and they were describing them in what we now know is PCOS. They didn't know what it was, of course. So really it was the early 20th century. And it was two physicians named Stein and Leventhal who presented like the first cohort of women. I think it was 6 or 7 women that had a cluster of three conditions, and realized this would get further. It would get further diagnosed later on. Like clinically, they didn't still know exactly what was going on. And they presented these women, and they called it and one of the main things they saw was multiple cysts on the ovaries, right? Polycystic ovary syndrome. They also saw indications of elevated androgen levels, which tend ever like testosterone, DHEA, hormones like that. And this is very common. I don't think at that point they were doing blood testosterone tests. It was very new. So they sort of saw it, but they didn't know what was causing it. And then they also saw menstrual cycle dysfunction. So this was termed, originally it was Stein-Leventhal syndrome. And then polycystic ovary, and the names changed a little bit. Okay, now let's move up to now. There are multiple criteria that are used. They're basically different medical groups. The most common one used is called the Rotterdam criteria. Okay. And it is named that because it was developed at a conference held in Rotterdam. And their 3 criteria for PCOS are multiple cysts on the ovaries, right? Polycystic ovary syndrome, menstrual cycle dysfunction, which can be anovulation, oligomenorrhea, which means an extended cycle. That means one cycle every 35 to 90 days, or full-blown amenorrhea, the lack of a menstrual cycle. And elevated hyperandrogenism, elevated androgen levels, which can either be determined biochemically, blood tests, or basically dermatologically. You will see things like excess body hair. You may see acne, oily skin. Okay, but the way they defined it is a woman can be diagnosed with PCOS if she has any 2 of those 3. And when you sit down and make a little chart, right, you end up with 4 different subtypes, right? You can have all 3, and that's the classic version that Stein-Leventhal identified, right? So you've got polycystic ovaries, hyperandrogenism, menstrual cycle dysfunction. You can have polycystic ovaries, hyperandrogenism without menstrual cycle dysfunction. You can have hyperandrogenism, menstrual cycle dysfunction without polycystic ovaries. And that's where it's a little confusing, right? Like, well, how can it be polycystic without polycystic ovaries? And I'll come right back to that. And then the 4th type, you can have polycystic ovaries, menstrual cycle dysfunction, but no hyperandrogenism, right? So you get 4 subtypes. And the type with all 3 has the worst clinical outcomes. Like it is the worst of the 4 types, and then the type without hyperandrogenism has the least negative effects. And I forget where the 2 in the middle go, but it's kind of descending in terms of the negatives that are seen. And so like I said, it's a little confusing. How can you have polycystic ovary? And it's because that's the old name. Within another 10 years, they will probably rename these into separate. Right now, it's just PCOS type 1, I think it's like type A, type B, type C, type D, and they've got different names and stuff. And other people have suggested other diagnostic criteria, such as excess body hair. One paper I read, they have like 27 subtypes. Nobody has adopted this yet. Like, no, I don't know if they ever will. Now, there are others. There's a Hyperandrogenism Society that uses slightly different criteria, and there's a 3rd one I forget off the top of my head. Rotterdam is the one that's used most commonly. So you've got all these types. But I wanted to loop back to that first question. So in polycystic ovary syndrome, you have this syndrome in terms of hormonal dysfunction, hyperandrogenism, and cysts on the ovaries. When I was reading about polycystic ovary disease, the way it was described in these articles was that the ovaries produce lots of small eggs that then become cysts, which start producing androgens. And I didn't, like, I think I couldn't really figure out exactly what distinction was being made, quite honestly. But it seems to me that it kind of leads to the same place.
Mm-hmm.
And again, I don't know if PCOD is just an older descriptor. I don't really know, but so those are the 4 different types. Like I said, you see a worsening of effects, and I'll come back to why. Now, just for completeness, even in that 4th subtype, without elevated blood testosterone levels, what you do often see is elevated androgen levels within tissue, within muscle tissue. And there are people that are like, look, all forms of PCOS are hyperandrogenic. They all have elevated levels of androgens. And that also includes DHEA. You also see a higher free testosterone, something called the free androgen index. And that just gets into the clinical manifestations. Also, you can diagnose PCOS without the blood work. Like, and you can speak to this. I mean, you said you have 8 out of 10 women that you train.
Yeah.
There is a common, like I said, facial hair is very common. Acne may be present. Hair loss can occur. It's in a very small percentage of women. There's typically a more of a central, like more male-like fat pattern around the middle. One difficulty that does come out of using like body hair as a diagnostic criteria is there are ethnic differences, right? In sort of how much body hair different. I mean, I'm Middle Eastern, and we have a lot of body hair. So that can be a really difficult criteria because they're just now finally starting like, look, we've only really looked at, Caucasian women in the US. If you're looking at different cultural groups, different ethnic groups rather, you may have to use slightly different criteria. So just it is a consideration. So, we're now 80 years into knowing about this disease clinically. It is still developing with the research. Most of it, I think, will be slight distinctions in terms of what I think the treatments may be. Although, in the broadest sense, they tend to be very similar. There is one major distinction I will. Well, I might as well address it now, which is just in terms of like the negative effects of PCOS. Like I know this wasn't a specific question, but I think it's worth addressing because you see this real cluster of negatives. One of the most common is insulin resistance. And you see that in something like 60 to 70% of PCOS women. Also, obesity and excess body weight and body fat is extremely common in PCOS. And in PCOS women that are carrying excess body fat, insulin resistant goes to about 95% of women. Like it might as well be universal. But there is a lean subtype of PCOS. Not all PCOS women gain weight and carry excess body weight. So there is a lean PCOS subtype. And I suspect, but I haven't seen the data, I suspect that fourth subtype, kind of the mildest form, is probably the one which is most likely to be lean. And I'll explain why. Elevated androgen levels in women, and again, here I'm talking testosterone, DHEA, there's a couple of others that I don't want to get too deep into the weeds in this, in women cause insulin resistance. So when you have elevated androgen levels in women, in men it tends to improve things, in women it makes it worse. And in that 4th subtype of PCOS where you don't have elevated testosterone levels, I don't think you're seeing that regardless. But then what happens is that elevated insulin levels cause the increased testosterone production. So you get this real negative cycle, where elevated testosterone causes insulin resistance. Couple that with diet and lifestyle, low activity, lots of refined carbohydrates, elevated insulin levels, more testosterone, more insulin resistance, and it just becomes this very bad cycle. So that's one of them. You get increased visceral fat accumulation. Again, that male fat pattern, which predisposes women with PCOS to a number of diseases. You typically see issues of binge eating is very common. Increased appetite, probably due to the androgen levels. You see increased levels of anxiety, depression. And it's hard with that to say, is that hormonal? There can be sexual dysfunction, some of that, and realize this is what the researchers are saying, having to do with body image issues, right? For women all over the world, physical appearance is important. And if you're carrying excess body fat, if you have excess body hair, relatively speaking, that's it. So you get this whole cluster of issues that really, really, really cause a tremendous amount of problems. But you do see slight differences, right? Because one of the primary treatments for PCOS is weight loss. Well, for the lean PCOS woman, weight loss isn't an option. Or isn't a target. And this is just a long way of that. What we may see down the road is we see sort of a distinction between these different subtypes, that there may be slightly more targeted treatments. We're not there yet. One thing I did want to mention, going back to the diagnostic stuff, for some reason, physicians just don't think to test this. And I don't know why. And I think, again, part of it, a lot of things can cause menstrual cycle dysfunction in women, a tremendous number of things. So if that issue is there, like, you have to sort of eliminate other possible causes. Women can produce elevated androgens due to certain types of tumors. You have to eliminate that. And I think in a lot of cases, physicians focus so much on those other causes, or the insulin resistance, which can be diabetes, metabolic syndrome, lifestyle, that it sort of doesn't, like, almost doesn't occur to them to go ahead. And whereas if you have someone who's experienced with PCOS, who has a woman with PCOS come in, this will sound, I hope your listeners take this in the way that I intend it, is frequently when you see women with PCOS, you can tell there is a, because again, they tend to be carrying a lot more fat around the midsection. Their facial structure is often a little bit different. They may have, a little bit more facial, like, to me, if I, again, I have a background. If I were a physician and I had a woman come in and she described this cluster of behaviors to me, I only menstruate every 45 days or not at all. My blood sugar is unregulated. I've got excess body hair. I have to shave body hair. My first thought would be PCOS. Like, I wouldn't even worry about the other stuff. That would be my first guess. And whenever I've talked to women that went years without a diagnosis and finally found that physician with experience, they walk in the door and the doctor's like, oh yeah, there's not even, we'll still do the testing, but there's no doubt about it. Even now when I do consultations and women are describing, they go, yeah, since I was 15, my cycle has never been normal, or it's every 45 days and I carry excess body fat around my midsection. I'm like, I know what's going on already. Say no more. So there are these 4 different types with subtle differences, but in the aggregate, like that 4th subtype, because the androgen levels aren't as high, insulin resistance is not as common or as frequent. Even when you look at the data, like, I think this first subtype is like 50%. The second and third are like, the 4th subtype is only like 10% of PCOS women, but I suspect it's more than that in the real world. And here's why I say that. I suspect women with that 4th type, which is so much milder and so much less significant in the negative that it's caused, I have a feeling they don't go seek medical treatment. So I suspect, and I could be completely wrong about this, I suspect they are underrepresented, statistically speaking, because it just wouldn't occur to them because they're not having the same problems that are seen. Anyway, so yes, there are different subtypes with subtly different effects. So I think we can move on from that.
Yeah. So what I can understand from you just said is that this has been going on for like decades and decades, and the information of this was mentioned in scriptures years before. And there are subtypes, and PCOD and PCOS are somewhat the same. PCOD must be a little older terminology.
Yes. If you give me 1 second, I'm going to pull up something I wrote really quickly that talked about some of this.
Yeah, for sure.
I'll read just because it is interesting reading these, centuries old descriptions. Going, like I said, in hindsight, we can look at this and go, oh yeah, absolutely. Let me make sure this is the right chapter. So let's see. So this is in the late 16th century. A French physician wrote that many women, when their menstrual cycle was lost, take on a certain manly nature, at which point they are called viragenes, that is to say stout or manly women. There's an old word called, you'll see it virago, and the ancient meaning of it is like warrior woman, and it's kind of, like stout manly woman. Now it took on a much more negative connotation more recently. In 1721, described the case of a young married but infertile peasant woman who was moderately obese with 2 larger than normal ovaries. In 1844, the observation of small cysts on the surface. In the 1920s, 2 different groups described polycystic looking ovaries in 2 women who were oligomenorrheic, meaning that they had a longer, their menstrual cycle was longer than between 35 and 90 days, and who suffered from pelvic pain. And so it's 1935 that Stein and Leventhal described patients with polycystic ovaries, excess body hair, because again, that they didn't have the blood work, and menstrual cycle dysfunction. And they got the cover of the issue of the American Journal of Obstetrics and Gynecology in 1935. Like, it was that important. Here we go. By the 1950s, the term Stein-Leventhal syndrome was in common use, although others were using the terms polycystic ovary disease or polycystic ovary syndrome. This would continue until the 1970s and 80s, when Stein-Leventhal had fallen into disuse. So I think it's just an older term. By the 1990s, PCOS was used almost exclusively. Like, so I looked on PubMed, it was all like early 80s papers. So from what I can tell, they are functionally identical. So yeah, so we've had this for centuries, and it's only in the last, it's like 90 years that it was actually really diagnosed and seen that huge development.
So what I can understand is a lot of different factors coming together and make PCOS.
And that's worth kind of addressing briefly. So PCOS it's one of those things. There's a genetic component, because there's always a genetic component, and there's an environmental component, because there's always an environmental component. So PCOS does tend to run in families.
Okay.
Women with PCOS tending, but what's really interesting, I found as a random thing, they are now talking about a male form of PCOS, which seems a little strange. And it has to, you still see some of very similar things in terms of elevated androgen levels and some of the same effects. Brothers of women with PCOS are like twice as likely to have this male form of PCOS. So that, which really points to this real major genetic component. And then, and so you've got the genetics. There are some thoughts that what happens during fetal development may be impacting this. So for example, we know, there's been a lot of work on this in recent years. Is the fetus being exposed to elevated levels of testosterone that causes biological programming? I'm sure you've looked at, the 2 to 4 finger ratio and all that kind of stuff. That may be part of it. It may be exposure to cortisol is one thought. There's something called anti-Mullerian hormone. And so that's a little bit harder to figure out. It's a lot of animal work, maybe exposure to that. There may be environmental triggers that are occurring after birth. And then certainly, obviously it tends to show up at puberty. And, which it is a reproductive disorder. But even there, like, there's an idea that, sort of becoming obese can cause PCOS. That's not really the case in anything I've ever seen. It may trigger it. It may cause it to manifest, certainly. But then again, if you've got elements of PCOS predisposing towards gaining excess body weight, I think it's a little hard, but there's absolutely genetic component, maybe prenatal programming, and then there probably are some environmental triggers. And it may be, again, I haven't looked into this or seen any work on it. I mean, it's possible that it can occur later in life. Usually, the couple examples I've seen, it's usually because it's masked by something else. And actually, one of your later questions, I'll come back to that, so I won't get too far into that. But yeah, so there's absolutely this humongous genetic component. And then again, other biological factors that they're still trying to kind of work out. And then, and it's actually it is interesting, and this leads into the next question. Women with PCOS tend to have less reproductive success when they're younger. They do have problems with fertility. So the question with this stuff, the question always becomes, why? Why is it maintained, right? in an evolutionary sense, in a reproductive sense. Anything that impairs fertility. And the paper I read that talked about this male form said, well, men with PCOS may get benefits reproductively because they're more aggressive, they have higher testosterone, they're more fertile. So because the men are getting reproductive benefits from it, they may be the ones helping to sort of maintain it in the gene pool. So pretty much, you know, as is always the case, it's our fault. I mean, I'm semi-kidding, but yeah, so that sort of ties in, but it sort of ties into that, but the huge genetic factors.
Wow, I never had heard this before, that even men have some form of PCOS. I mean,
well, I've only seen a couple things about it, and let me see if I can pull up something. Male equivalent PCOS, defined as disorder that occurs in male members, characterized by the clinical signs of androgenism, complete hair loss, and the same hormonal patterns seen in PCOS, except for testosterone levels that are in the subnormal range. So there is a male equivalent. And yeah, I only came across this fairly recently. I think this is a fairly new kind of thing. But just the fact that it runs in families, in men and women, sort of that really points to that genetic component.
And when coming to the treatment of PCOS, why do doctors prescribe birth control pills to women? And is there any side effect attached to it?
Okay. Do you want to address that before the infertility and cancer question?
Oh, no. Please go ahead. Yeah. Yeah, let's go ahead with the PCOS. Can PCOS cause infertility and cancer? That comes first.
So I'll do the second one first. As far as cancer, there's increased risk of endometrial cancer.
Okay.
However, there doesn't seem to be any convincing connection with other forms in terms of breast cancer, ovarian cancer. There doesn't. So that one, endometrial cancer, and I think that's because when you've got the infrequent periods or absent periods, you may see the endometrium is not being shed every month, and it's probably, so there is it's like a 2.7-fold increased risk of endometrial cancer. Yes, but other types there does not seem to be. So far as infertility, absolutely. Something, and don't swear me to this number, but something like 80% of the women who go to fertility clinics with anovulation, meaning they're not releasing an egg, something like 80% have PCOS. So yes, absolutely. That is one of the primary effects, and that ties into the menstrual cycle dysfunction. You're frequently seeing, you may see this very extended cycle, like I said, between 35 and 90 days. So you're only getting, you may only be getting 4 cycles a year, right? Yeah. There may not be an egg released, or there may be no menstrual cycle whatsoever, amenorrhea. Again, if the egg is not released, the endometrium is not formed, so there's no bleeding. So yeah, absolutely, infertility is one of the most common negative effects of PCOS, which is obviously, an issue for many women who want to have children. And that's part of why the lack of diagnosis can be so problematic, is, that's 10 years where they could have been treated and tried to make progress with this, lost, because there are ways, it's addressed in a lot of ways, and many of them are medical and are really outside of my area of expertise. They do a whole bunch of different stuff to try to get things back online in fertility clinics, but there's also a lot of the frontline treatments as far as weight loss, exercise, the things we're going to talk about, that drastically improve fertility rates in and of themselves, and then they may also go medical if they need to. So yeah, absolutely. However, I did not see anything, or I've not seen anything suggesting that it can cause a permanent infertility. It is simply a consequence of sort of having untreated PCOS.
Okay.
Just because the entire hormonal system gets so knocked out of normal function. And what you'll see kind of as we go through this is that as much as the insulin resistance is a problem, certainly for health reasons, increased risk of diabetes, metabolic syndrome, you see elevated blood lipids, elevated cholesterol, inflammation, like 8 times as much depression, like all these other problems. The elevated testosterone is really kind of the crux of all of this, right? Like that's really what is driving most of the issue. And there are admittedly 2 different ways to go about this. But first, let's go to the birth control. The reason they use birth control is oral birth control, actually all forms of birth control, lower testosterone levels by about 50%. And that's why they use it, is in that those elevated androgen levels, those elevated testosterone levels are driving everything. Cutting those helps break that cycle in terms of improving insulin sensitivity. Now, obviously, that's not going to help you get pregnant, right? Sort of by definition. But what it is, it's a first-line treatment to try to get things back under control and deal with all of those health consequences. So far as harmful, no, not. I mean, like I said, that is one of the classic first-line treatments, and even there's also one of the newer, the newest form of birth control. It's called Yaz or Yasmin in the States. Combined birth control uses a synthetic estrogen and a synthetic form of progesterone. And the newest type of synthetic progesterone, it's commonly called drospirenone, is anti-androgenic. So it actually will block testosterone from attaching to the androgen receptor and sending a signal. So that's almost having a double benefit. A, it's cutting levels in half, it's lowering free testosterone, but it's also preventing testosterone from binding at the receptor. So yeah, that is absolutely a very standard approach to at least try to get things, to deal with the health issues. Another one that's used, and this sort of addresses it from the opposite direction, is a drug called metformin.
Yes.
I don't know if you're familiar with that. It's used in diabetes treatment. It's an insulin sensitivity, insulin sensitizer. It affects skeletal muscle, it affects liver, tons of effects. Like I said, you've got this situation where elevated testosterone causes insulin resistance. Insulin resistance causes elevated insulin levels. Elevated insulin levels raises testosterone. So you can either cut testosterone or improve insulin sensitivity, which will have a secondary effect of reducing testosterone levels. So that's another first line treatment. And there's a whole bunch of others, that you will see stuff. They'll talk about using appetite suppressants for weight loss. They use a lot of things, dermatological treatments to help address, like that's not improving the endocrine a lot, like using Accutane or something to treat acne or body hair is obviously not going to decrease androgen levels, but it may help with some of the external manifestations, which may be affecting, depression, anxiety, self-esteem, et cetera, et cetera, et cetera. But what you also see is that if you can reduce androgen levels over the next 3 to 6 month period, many of those issues with body hair, with oily skin, with acne will start to improve on their own. Which may not, again, this is more physician end of things, which doesn't mean they won't be using those things as well for short-term treatment, just to deal with them. But yeah, it really comes down to sort of that approach, either improving insulin sensitivity, lowering androgen levels, or both.
So when it comes to birth control pills, are they prescribed only until the time when things get back to normal, or do they have to consume them like forever?
That, what, honestly, I don't know. What I would expect, I said at this point, you're kind of getting into the medical realm, which is a little bit outside of my expertise. What I would expect they would do, or what I would hope they would do, is use this in conjunction with lifestyle change. And we're going to talk about that next.
Right.
Because if you can, because you've got all these issues, elevated androgen, insulin resistance, excess body weight, which contributes to the insulin resistance, all these other things going on. If you can take even 5 to 10% of body weight off, that will drastically improve insulin sensitivity, lower androgen levels, and start to correct it. Using the drugs up front may help with the lifestyle treatments. The one thing I see a lot in the literature, and I don't agree with this personally, there's this idea that, we should do the lifestyle stuff first. Let's get them change their diet, get them exercising, and then if that doesn't work, let's use the drugs. To me, to me that doesn't make any sense. Why not throw it all at the problem, right? Metformin can sometimes help improve fat loss on a diet. If testosterone levels are driving binge eating and elevated appetite, why not cut those up front, right? It's like the idea of like, oh, we're not going to give you like one of the new dieting drugs, like Ozempic, semaglutide, liraglutide that are real popular right now. Like, oh, we're going to get you on we want you to lose 10 pounds first or lose 5 kilos before no. Don't use it instead of the lifestyle. Use it as part of a comprehensive treatment. Because if you can address those, the biological issues as you're introducing the others, that in my opinion, will improve everything. And the way I sort of conceptualize this is, like I said, we've got this real negative this negative loop. Elevated androgens, insulin resistance, hyperinsulinemia, androgens, which means increased appetite, binge eating, depression, anxiety, low self-esteem, which is not going to do much for your eating patterns, right? If you're dealing with all of this. And then you gain more body weight or body fat, insulin resistance worsens, you get the idea. To me, the idea is to get the cycle going in a positive direction. I did, like a couple of years ago, I did a diabetes podcast, and they said that was absolutely their approach. Because if you can get things moving, we can improve insulin sensitivity, lower androgen levels, decrease appetite, decrease binge eating, decrease anxiety, depression, improve self-esteem while we're introducing diet, fat loss starts, everything gets moving in the right direction. And then at the point where, activity levels are sufficient, or I'm sure there's body weight cutoffs, women should be able to come off birth control. So that they can then move if becoming pregnant is their goal, because obviously they're gonna, at some point they're going to need to do that. And I don't have the statistics offhand. I can probably pull them up in the background, but even small amounts of weight loss, like an regular activity, the improvement in fertility rates is just staggering with lifestyle changes. But to me, if the medication improves, makes it easier to stick to lifestyle modifications, we're definitely going to touch on that, then all the better. Why not use every tool at your disposal? It's kind of the way I look at it. So
coming to our next question, what are some lifestyle changes that can help the situation, and can PCOS be cured permanently?
So cured is a weird word. This gets semantics. Like, the genetics are never going to go away, right? That specifically. However, if body weight comes down, if regular activity, that improves a staggering amount of it. So one thing I've got in one of my notes, even a 5% loss of current body weight improves many elements of PCOS, with 40 to 50% of PCOS women showing an improvement in ovulation, and 30 to 40% achieving spontaneous pregnancy without any sort of fertility treatment, right? So that's 5% of body weight. So if you've got a woman who's, say, 100 kilos, that's a 5 kilo loss. When they've looked at like bariatric surgery, right, where they do like stomach stapling or that, where women will lose people lose like 50% of their body weight, there's basically a complete elimination of all symptoms. Now, is it cured? Yes and no. I mean, I think you kind of see where it's like the genetics are always going to be there. The propensity is always going to be there. And if things go backslide, it's probably going to go back to where it was. But so far as body weight is kept under control and activity patterns are maintained and all of that stuff, all of the improvement should be maintained. If that makes any sense. I'm just looking over. I had sort of a list of different the drug treatments that they used, and we basically all. But so as far as overall lifestyle, it's genuinely the same stuff we kind of tell everybody is dietary modification, exercise, dietary supplements, and there are certain things that are seen, that are vitamin D, fish oil. And the thing is, it's always the same stuff, like whether it's PCOS or in general, but these are especially problematic. A lot of nutrients involved insulin sensitivity, things like magnesium are often very low. There's one supplement I do want to talk about that has profound effects. We'll come back to that. So yeah, dietary modification, exercise, dietary supplements, and then pharmaceutical approaches. Like that's the generalized treatment in the same way that it's the treatment for everything. Not particularly helpful because that's not very specific. But as far as the diet, what it really comes down to is generating fat loss. Like we tend to talk about weight loss, but obviously you and I both know, and I'm sure your listeners know, fat loss is far more important, especially visceral fat loss, which testosterone, androgens tend to promote visceral fat. That's why men tend to develop that. The loss of that has a profound effect in terms of health, insulin sensitivity, everything else. Again, in that lean PCOS subtype, obviously weight loss per se is not a factor, but you're not usually seeing the enormity of the symptoms. So it's not, it's not quite as big of an issue. So as far as diet treatment, we then have the question, is there an optimal diet for PCOS? And if you kind of read the research, they say, well, not really, so long as it causes weight loss, which is fine. And we sort of know that in a physiological sense, there's no difference, right? To any significant degree. However, well, this actually kind of, this jumps to your last question. And I want to move it forward because I think it's worth addressing because to me, it really brings the big problem, right? Because there is this idea that PCOS women have more difficulty losing weight. See this all the time on the internet. Now, when you look at the research, this does not seem to generally be the case. When they take women with PCOS and without PCOS and put them on the same dietary intervention, weight loss is the same for the women who adhere to the diet. And I use that language very specifically because there is a sort of hidden piece of data in those weight loss studies, which is that we know that diet studies have high dropout rates. Like 25% is pretty normal, somewhere in that range. PCOS women show like a 50% dropout rate in diet studies. It's enormous. Now, I'm not saying, and please don't ever hear me say like, oh, PCOS women are just lazy or blah, blah, whatever. It's not that. If you look at the biology of what's going on, think of how difficult it would be to adhere to a diet when you're dealing with depression, anxiety, low self-esteem, binge eating, runaway appetite. PCOS women I didn't even mention don't seem to respond as well to gut hormones that help signal the brain that the appetite is there. Of course, they're not going to be able to adhere to the diet because of the huge cluster of negatives that the PCOS is causing. So to me, the question then becomes, it's not even so much, there are they've compared, all right, low carbohydrate diets may have some, because we know that with insulin resistance, generally lowering carbohydrates tends to be superior. Although even there, the research tends to go, well, it doesn't really matter. Then when I read those studies, the high carbohydrate diets are the carbohydrates nobody eats, in my experience. They're like, yeah, if all you eat is low glycemic vegetables, that's not how people eat in the real world. So I don't care. In most cases, lowering total carbohydrate intake tends to be a little bit easier than trying to get people to eat, the less refined stuff. So then to me, the question really is less about, what's the best diet for fat loss? Because we know it doesn't matter. It's what diet or what dietary modifications can we make to help improve adherence, to address the issues that PCOS women are facing that are causing this low adherence rate. And one of the papers I've got, it's, basically addressing the barriers to adherence. And we see this in lots of different domains. What is the biggest barrier to adherence to exercise? Time. People simply, I don't have time. So, we then get into the question, what is the barrier? What is causing PCOS women? I sort of I addressed a lot of it So, in many cases, again, when there's insulin resistance, moderating carbohydrates just makes sense, right? I've got a paper from like 20 years ago. So the optimal diet for metabolic syndrome is something like that. And it was like carbs at 40%, dietary fat at 25 to 30%, and the rest protein. It was like right in that realm, which, yeah, to me is, right about right. I'm trying to, so in this thing I was sort of working on, oh, there we go. Right, so what I wrote was, the critical component of designing an optimal diet for PCOS. It should also help to improve adherence, reduce dropout rates by addressing fullness, mood state, and all of the other barriers that can make it difficult to lose weight and fat. Because PCOS women have the same issues that all dieters go through, and then all the PCOS stuff tacked onto it, which just makes it that much harder. So as always, anyone who has, read, so here's just, again, I know I'm jumping around here. This is from a paper called, is Barriers to Weight Loss, Fat Loss in Women with PCOS. Psychological factors: anxiety, depression, lower self-worth due to carrying excess body weight, disordered eating, increased appetite, cravings for sugar and fat, it's all of this is just making it that much harder. So anyone who's read anything I've ever written knows I start with protein. I always start with protein because that, to me, like that, for any diet, if you get, a calorie deficit and enough protein, you're pretty much ahead of the game. The rest of it tends to be a lot less consequential in the big picture. But what is really interesting is that here there are several studies in women with PCOS that protein just has profound effects. Okay, now number one, we know that protein tends to be the most filling nutrient in and of itself. So that can only be a benefit for all dieters, but especially in this case. Helps to stabilize blood sugar levels, super critical when you're dealing with insulin resistance and elevated insulin levels. Sufficient protein with exercise, make sure you don't lose muscle when you're dieting, obviously important. There are three different studies with PCOS I kind of want to address. One gave 30% versus 15% protein, 112 grams per day versus 56. No difference in weight loss, but the higher protein group women did have a greater decrease in waist circumference. So there was a greater loss of visceral fat. Okay, that's good. Second group, 40% or 15% protein. So about 145 grams per day versus 105 somehow. They were not told to restrict calories. Over 6 months, the high protein group lost 4.5 kilos of weight and 4.3 kilos of body fat. It's nearly 100% body fat.
Wow.
Lower protein group lost 3.2 kilos of weight, 2.1 kilos of fat. So just by ramping protein up without restricting calories caused that significant fat loss. And then the final one, which is almost as interesting to me, compared 30% or 15% again, same as that first study. No difference between groups in terms of weight or fat loss. The higher protein group reported a decrease in depression scores with an increase in self-esteem. Now, the researchers don't know why. Might have been amino acid levels. Who knows? But to me, I don't care. In a very real sense, just doing that one thing, just increasing protein to higher levels. And this came out to, when I mathed the stuff out, it was between 2 grams per kilo to a high of like 2.8 grams per kilo of lean body mass of protein. So probably higher than many women are used to. And yes. I know, and I'm aware, also I know that depending on, I think we talked about this last time, I know culturally in India, often protein intakes are not high. That can be its own barrier for cost, taste, religious, cultural, all kinds of reasons. But that's kind of like that. That to me is the fact that one change can have such a profound effect. Appetite, fat loss, and especially even the psychological stuff is absolutely definitely huge. And then honestly, the rest of it, when you look through the literature, it's just the same stuff you always see. We need to limit trans fats. Mediterranean diet gets a lot of press with lots of healthy fats, olive oil, things of that nature. Fish oils definitely have been shown to have huge benefits, omega-3, which I would recommend that to anyone. And then, ideally, keeping carbohydrates moderated with lower, avoiding simple sugars in excess. Like, there's not really anything that new. Most of it is just making sure that it's set up, again, to control appetite, blood sugar, can be adhered to, fits taste preferences, all the same sort of thing. But there doesn't seem to be any real indication other than the behavioral stuff that fat loss should be any, like I said, it's just really, it comes down to, it may be more difficult for PCOS women to adhere. But even that's where, to me, some of the drug stuff, if birth control, if by lowering androgen levels helps bring appetite, cravings, binge eating under control, that's nothing but a benefit, right? If metformin by improving insulin sensitivity is doing the same thing, that can help with the behavioral stuff. Just as one, do I even want to get into this? Okay. Have you ever talked much about glycemic load on your podcast?
No.
Concept. All right. So, the glycemic index, right? Which is sort of an old measure that's really not very, very useful. It has to do with blood sugar response of foods to a reference food, right? They've kind of gotten away from that because the glycemic load is more important. Glycemic load is the glycemic index times the total number of carbohydrates, right? Because you can have a food with a super high glycemic index, like carrots, but you can't eat 100 grams of digestible carbohydrate of carrots. Well, I'm sure somebody can, but by and large, whereas you can eat 100 grams, digestible grams of rice or very, very easily. So the glycemic load sort of normalizes that. And now what they're really talking about is rather than trying to lower glycemic index, is to lower the total glycemic load of the diet. You can do that one of two ways. You can eat the same amount of carbs and lower the glycemic index, which means less processed, higher fiber, etc. Or you can not worry about the type of carbohydrate and just eat less. That will also lower the glycemic load. Anyway, but some studies have looked through the math on this to see how dietary changes will impact glycemic load, right? So there have been studies where they're like, we're going to replace 20% of carbohydrates with 20% monos. We're going to raise dietary fat to 40%. That will reduce glycemic load by 40 units per day. Just 40. That's all you need to know. Replacing carbohydrates with protein, 35 units. If you reduce the glycemic index of the carbs you are eating from 70 to 50, 40. So to me, it's probably just easier to raise protein, eat moderate amounts, and just reduce the total amount of carbohydrates. But, I would also expect, honestly, and this hasn't been looked at, if you replace some carbohydrates with protein and some of your carbohydrates with monounsaturated fats, I bet the effect's even greater, but nobody's studied it. So anyway, it's pretty much what I would recommend. Raise protein intake to, ideally 2 grams per kilo. Even if you can get to 1.5 grams per kilo, that would be a huge step up from the protein intakes I typically see in women. I imagine you do as well, often very, very low.
Yes.
If it can be a little bit higher, great, but even increase the intake of dietary fats, ideally from healthier fats, and just moderate total carbohydrate amount. Some women might benefit from full-blown low carbohydrate diets at the extremes, but I think for most, moderate, and again, if you're in a cultural area where carbohydrates are really a primary part of the diet, good luck not eating any. It's just not. I remember I did a consult, and I forget. All I just know is ethnically his diet was based around, and he's just like, look, I don't even have much of a taste for protein, and if you tell me to do no carbs, I won't do it. He's like, I have to be able, because I have grown up eating like this. And I get that. We have to work within those parameters. So sometimes just moderating it a little bit. You see in women so often 80% carbohydrate, 10% protein, very low fats, or often the opposite, very low protein and a lot of, I mean, this is, I know something, Sumi has talked about, like I know traditional Indian cooking, ghee, butter, lots and lots of fats. And I get it, it's a cheap source of calories. I understand that completely, but you will see that sort of very skewed dietary pattern. And if you can even just get it moderated with protein a little bit higher and bring carbs down a bit, that frequently is all you need to do. But it, like I said, just raising protein alone seems to do most of the heavy lifting.
So I know a lot of women who would like to increase their protein intake, but they just cannot eat so much food. So for them, would supplementation be a good idea? Whey protein or something?
Yeah, I mean, if you have to go down that route, and this is a reality. There's a biology to it where often men tend to crave protein and fats, and women tend to. Many women I've met just don't have a taste for protein biologically, and then you add to that, if you weren't raised eating much meat or eating much protein, you just don't have a taste for it. So in that case, if you have to use a protein powder or what have you, that may be necessary, and certainly if that's what you have to do, that's what you have to do. I can't remember if it was you and I that talked about this during our lab. Were you the one that told me that protein powders in India are either are really bad or are rumored to be really bad? You could tell me.
It was me. Yep.
Remind me what it was specifically the issue was.
Well, I think just 6 months before I had a podcast with you, a racket was busted by the police where they were selling fake protein powder, which had I think sawdust and sugar powder and stuff like that.
Oh gosh.
Yeah.
Okay.
So that is, so that was the issue.
Is there a way to ensure quality control? I mean, are there brands that are known to be better than others?
Yes, there are. Yes.
Protein.
Yes. So if a person buys the protein powder directly from the brand's website online, it's much better and safer as compared to buying it off different delivery websites like Amazon or something like that.
Gotcha. I gotcha. But no, that's absolutely an option, and frequently that's if you've got. Years ago, the clients I used to have, female clients, and they would tell me, their breakfast, and it was always, nothing but carbohydrates and fat, and they'd be hungry 2 hours later. Just add something with some protein in it. I don't even care what it is, and that alone. So yes, if a woman just has no taste for it and needs to have a scoop of protein powder in water, or I don't know if milk is a big drink over there.
It is, yeah.
Mix that in there just to get some protein. It's always been really interesting to me is often getting women to eat more protein can be a real battle for the reasons we talked about. But when you do, once they've done it for a little while, the benefits they notice are so profound.
Yeah.
That it's just because, again, appetite comes under control, blood sugar comes under control, they feel better. Frequently, depending on what they're doing for exercise, they start to see changes in appearance, body composition, muscle tone, et cetera, et cetera. And once you can just get them doing it for a couple of weeks, then once it clicks, then it's like weight. I mean, it's even like weight training with female clients. And they're like, I'm afraid of getting big or this or that and the other. And you're just like, just trust me for a month. Just put your faith in me. And then once they give it a month and you train them properly, and that's it, they're sold. So but absolutely, I think that is an option. If that's the only option, that's the only option. So, so be it. I see I wouldn't want the entirety of protein intake to come from powder form, but if that's going to be the only way to bump it up 30 grams, then absolutely.
Yeah, because as we talked about this issue last time, that India has the highest number of vegetarians. So that's another thing, that if they are convinced to consume protein powders, it's going to help them a lot. So
and and that's always been an issue, depending on the strictness of the vegetarianism. That most vegetarian protein sources have so many accompanying either carbohydrates, fats, or both. Like there just aren't really many pure like lean protein sources that are nothing but. Like yes, beans can be an excellent source of protein, things of that nature, but you're gonna get the if you make that, I guess, your only carbohydrate source. But if you're going to do that, I mean, I'm Middle Eastern, and we have a typical. I think all cultures do have something that's big, rice, beans, some kind of seasoning, whatever. Like that, every culture has that one way or another. But by that point, you're so far above your carbohydrate level that absolutely vegetarianism can make it more difficult, and that's where protein patterns certainly play. I'm willing to bet that. I mean, over here. We've got all of the fake meat substitutes and it's all vegan, vegetarian, and, that is basically trying to be meat without being meat. But that I have a feeling at this point is a very Western world, US kind of thing. More so than the rest of the world at this point. So, is there anything in the traditional Indian diet that is in the traditional vegetarian diet that is just pure protein? Is there anything that's available as an option?
I think only soy. That too sometimes comes with carbs, but other than that, no. Pulses come with carbohydrates. I was just talking to a client yesterday, and he said that his doctor said increase the amount of pulses that they eat in their diet for extra protein. And I said, that is true, but then it's not like a lean source of protein. It's not, you know what I'm saying? Yeah. So he was quite surprised.
Right. Because it brings in such an increase in carbohydrates.
Yeah, exactly.
Yeah. That has always been a difficulty. So.
Yeah. And you just talked about resistance training. Does that help with women with PCOS in particular?
So there's a lot less research than you would expect, right? So as far as so we talked about diet, exercise is obviously the other part of lifestyle modification, and it works through a number of mechanisms. One is by improving insulin sensitivity, because again, that's breaking just that vicious cycle is a huge component of this. We also know, that visceral fat tends to be more sensitive to especially aerobic exercise. Like diet alone doesn't necessarily, visceral fat just tends to respond much better to aerobic activity. There's been a lot of research on that. There's only been a few studies on resistance training at this point. But what is really interesting, there's a big meta-analysis last year that looked at this, and they looked at different intensities, durations. They were looking at everything, VO2 max, which is aerobic fitness, insulin sensitivity, androgen levels, and everything in terms of what they sort of found. And what they did find is that in terms of aerobic activity, that a higher intensity was better than a longer duration. Now they defined vigorous exercise, which ranged from 70 to 85% of maximum heart rate. So not all out, but challenging, not easy, not brisk walking, not very low intensity. We're looking that would be, what is that, 70% of say 200s, like 145 heart rate up to maybe 165. So in the challenging realm, because that tends to have biggest effect on overall aerobic fitness, reducing insulin sensitivity, calorie burning. But it didn't seem to have that big of an increase in lowering testosterone levels, which I personally find a little bit odd. Because generally in PCOS women, especially if fat is lost, everything pretty much improves. Whereas the resistance training studies did show a decrease in androgen levels. And I don't know why that would be the case. I truly don't. Mechanistically, why resistance training specifically would reduce either androgen levels, or again, so they call it the free androgen index. It's the ratio between total testosterone and the binding. It's not worth getting into. It's another indicator of androgen levels, and that improved with resistance training. Again, I have no idea why that would be the case, and they didn't either, but that's what they saw. And sometimes that's kind of the best you can do. And I think resistance training obviously has other profound benefits in terms of, we know it improves insulin sensitivity as well within skeletal muscle. And certainly you can use it to work muscles that are not traditionally worked with aerobic activity. Most aerobic activities are lower body. So that leaves a whole lot of upper body muscle untrained. So it can improve insulin sensitivity. One thing you frequently see with overweight in general, muscles get filled up with carbohydrates. That tends to decrease insulin sensitivity. Like once the muscles are full, they're just like, nope, no more. And they won't take up any more. By using resistance training, you can lower muscle carbohydrate levels, especially if you moderate dietary carbohydrates. That improves insulin sensitivity. You tend to see increases in fat burning within the muscle. So that's another profound benefit. So I do think it can help frequently with issues of self-esteem, physical appearance, done properly. I mean, again, I'm sure this is, you're working with more clients now. I mean, I did my time when I was younger and did it, but that's exactly what you see. Once women sort of get past the, must lose weight and that's their only goal, they either start to feel stronger or feel more functional, able to do things, or start to see changes in their appearance or whatever it is. That can have a profound, I think, psychological benefit. So yeah, there is some work using interval training. That again, we know that tends to have a significant effect on things like insulin sensitivity, fitness level. The problem always is the realities of doing that, especially for women starting. Like to me, interval training, that comes later, right? And even when I say, vigorous exercise seems to be of more benefit, you don't throw women into that right off the bat, right? The researchers are recommending, 120 minutes per week of vigorous activity. That's not where you start.
Yeah.
That's not where I would start anyone, whether they have PCOS or not. Like a beginning exerciser, you just don't do that because then they stop coming. Right? They stop coming back. You have to build up to that over 3, 4, 5, 6 weeks. While you're doing these other things. And then once you get to that and have done that for a couple and have sort of a fitness base, you might bring in, start to bring in interval training. That's how I used to do it with my clients. I would start them at a very easy level, just get them going. And then after a couple weeks, it'd be like, all right, you're doing 30 minutes at this. Every fourth minute, let's just bump it up a little bit. And just push them a little, like not all out interval training. Just like work hard, a little bit harder for a minute, and I'll bring you back down. And we'll do that. Okay, cool. Now you've done, 6 minutes, a little bit harder. And it does need to be a gradual progression. That's where obviously you as a trainer come in. And weight training, I don't think weight training needs to be a profound amount of the overall activity. Twice a week, full body, basic stuff. We'll get the job done. I will make one point I do want to make that I think is interesting and a little bit beside the discussion, but is worth talking about. PCOS women, especially the ones with the elevated androgen levels, make great power lifters. PCOS women tend to carry more muscle mass, have denser bones. They're often a little more aggressive. They, in my experience, I'll be real careful with how I phrase this. They may have a more, I hate to, hopefully your listeners, I live in the US. I'm a little overly sensitive to language stuff. We're crazy over here. They may have a little bit more of a masculine demeanor. And I don't mean that I'm not saying that like to be critical. It is.
No, I understand. Yeah.
And if they're, and there's even, if you start looking at high level athletes, something like 35% of like elite power athletes have polycystic ovary syndrome because their elevated testosterone gives them a huge advantage in strength and power sports with putting on muscle mass, with developing strength and power. So for women with PCOS who really, they like I said, if they want to get like muscularly big and strong, they will tend to have a little bit easier time with it. And may really respond supremely well to weight training. But we're really talking more about treating it in the sense of improving the health parameters, improving fertility, decreasing all the negative effects. And here I think you're looking at, the aerobic activity 3 or more times per week. In my opinion, that to me is going to be like with all fat loss approaches, that to me is going to be a better use of time than 3 hours a week of weight training, right? Yeah, weight training is fun. Aerobic activity is boring. Trust me, I get that. But from a calorie burn perspective, from all of the factors we're addressing, putting all that time into weight training is just not a good use of, again, people's very limited time.
Correct.
So aerobic activity three plus times per week, 100 to 120 minutes per week of vigorous, 70 to 75% of maximum heart rate, which that's doable. That's, if you use the RPE scale, that's challenging but not impossible, right?
Yeah.
Weight training 2 up to 3 times per week, basic full body workout, couple sets, 8 to 12 repetitions, basic weight training, especially in the early stages. Interval training could be up to 1 to 2 times per week if it's used at all. That to me would be after at least somewhat of a base has been developed. And the studies to date on PCOS, one used 4 by 4 minutes with a 3-minute rest. Now that's hard. I was an endurance athlete for years. I did more interval workouts than I cared to that. I wouldn't want to do that workout, genuinely. 4 minutes near all-out effort is grueling.
Yeah.
Another one they did was 10 by 1 minute on, 1 minute off. That to me is far more realistic.
Yeah.
It's tough. But even and with that, if I were training someone and we were deciding to move into intervals, the first workout I might have them do 3. 1 minute, and not even absolutely all out. I mean, go up above what they're comfortable with and do the 1 minute rest real easy. Like if you're on a bike, the 1 minute hard should be hard, but the 1 minute easy, just barely moving. Just keep your legs moving. And then go do that for a couple workouts, maybe go to 5. It might take 2 or 3 weeks to build up to 10. You don't jump into that because then your clients don't come back. And that doesn't benefit anybody.
Yeah.
There's even been yoga apparently has some benefits, although I couldn't hang on, let me pull that paper up again because I don't have it in my notes right now. I have a feeling that probably has more to do with mental health than anything. Nope. But again, all of that, any of that which helps. 30 seconds. I would have sworn it was in there. But that's another possibility a couple times a week. Again, we run into the issue of there's only so much time, right? You can only do so much. And I think if you have limited time, picking the best bang for the buck exercises, So if I was training them and I had 3 hours a week, I would have them lift for 20 minutes each time, very basic routine. You can get through 8 exercises, 1 set apiece in 20 minutes easily. And then you can follow that up with 30 to 40 minutes of vigorous aerobic activity. And those 3 days a week, they would be covering the basics. If they had time to do stuff on the other days, fantastic. But that would at least, cover the basic requirements, depending on what they have available. So that, like I said, it's in many, many ways, it's not that different in the sense of what the guidelines are. Actually, I read a paper last year and it was gave resistance training guidelines for all these different situations. And all it did was basically, I think it was women over the lifespan and it was premenopausal. And it really, all they did was repeat the same stuff 4 different times. It changed a little bit. In older women, you have to worry about balance and falls and flexibility and stuff. But for the most part, you're really not seeing major differences in this almost across populations. It's just, and you wouldn't expect it to by and large. I think honestly, in many ways, I think the dietary stuff, making sure that it's addressing those issues specific to PCOS is probably really, because we also know, and again, I'm sure you've talked about this on your podcast, is exercise by itself has very minimal benefits causes very little weight and fat loss. And that's true in women with PCOS. It's true in women without. It's true in everybody, unless you can do a ton of it. If you are an elite athlete who's doing 2 hard hours a day, yeah, absolutely. For the average individual just starting out, the amount of exercise they can do just isn't, they just can't do enough to have a real major benefit. So especially in the early stages, dietary modifications have a far larger impact on body weight, body fat, fat loss than activity ever will. Which isn't to say that down the road that may not change, right? You know, if you've got the way I always conceptualize, if you've got a beginner, diet plays the big role in fat loss and activity plays a much smaller role. But over time, you know, if you start and are progressive, in 3 months after they've lost 5 kilos and their fitness level is improved, they will be getting to the point that they can do enough with, or at least they can do, well, they're now able to do enough with activity that they won't have to push the diet quite so hard, because fitness is improving. And whereas they were only burning, you know, 5 calories a minute in the early stages of it, which is pretty typical. You know, that's 200 calories in 40 minutes. It's just, yay, it just doesn't do anything. But if 3 or 4 months down the road, they're now burning 10 calories a minute because their fitness is improved and burning 400 calories, or they're doing 4 or 5 days a week, that can have a very significant difference. We also know that exercise plays a much bigger role in weight loss maintenance than it ever has in weight loss. So to me, a lot of what exercise is doing here is supporting the physiology of the diet and or of the pharmaceuticals or the drug treatment in terms of improving insulin sensitivity, reducing visceral fat, just getting that cycle going. Because as the biology improves, it gets easier to improve it further. And then, like I said, we talked about, you know, dietary supplements. Fish oil has already talked about. Vitamin D. Literally everyone is deficient in vitamin D, and that doesn't, you know, unless you work out in the sun all day. I believe there's data. I haven't looked into this. Maybe you have. I know individuals with darker skin may need even more direct sun exposure. Yes. I don't know what, I haven't looked ever into that systematically, but that is another consideration. So most everyone is deficient in vitamin D, unless you live at the equator or work outside. That's pretty much goes without fail. So improving that. Said you often see low magnesium status. There's been a ton of work, and I think it's worth addressing, at least touching on this, of dietary supplement treatment for PCOS, because it's generally aimed at, you know, magnesium involved in insulin sensitivity, chromium, alpha lipoic acid. They've looked at like turmeric, curcumin, which deals with inflammatory stuff. That's, I mean, lots of people, inflammation is common in people carrying excess body weight and in PCOS. But one of the really interesting ones, it's a supplement group. They're called the inositols. Are you familiar with that at all? And there's actually like 9 different kinds in the body. It's sort of a general compound, but there's really 2 of importance here, which is myoinositol, right? Myo means muscle. So this is the one that's found in skeletal muscle. And it turns out that in women with PCOS, that insulin resistance is basically genetic, or it's endemic, right? We know that if you've got a non-PCOS individual who gains excess body fat, they will become insulin resistant as a consequence of gaining body fat. For with PCOS, it's within the muscle. It's part of the biology. And then gaining excess body fat makes that worse. And it turns out that they have low myoinositol levels. And if you provide myoinositol, that improves skeletal muscle insulin sensitivity. And as it turns out, it works as well, if not better than metformin, without negative side effects. Metformin can cause stomach upset in some people. It's been enormously well studied. But there's a second one called D-chiroinositol, which functions in the ovary. And again, don't want to get super deep in the woods with this, but you see these ratios within different tissues of myo-inositol to D-chiroinositol. And because of what's going on in PCOS, that ratio is completely reversed in the ovaries of PCOS women. And that's what's causing a lot of the problems with the infertility. And appropriate doses of D-chiroinositol drastically improve fertility. Like those two compounds, on top of decreasing androgen levels, improving insulin sensitivity. At the 3-month mark, you will see a decrease in body hair, severe acne, because again, it's sort of addressing the whole issue.
Mm-hmm.
And at least one research paper, I've seen some researchers say that the inositol should be a preferred treatment instead of metformin, because it has all the benefits with none of the negatives. It's not universal. Like you see some subtle differences in terms of effects on fertility in this and that and the other, but by and large, the inositols work just as well as metformin. Can improve weight loss on a diet. Really profound effects. And I think that's kind of it.
Yes.
Surprising, I usually talk for way longer. Was there anything else? With any other questions you got, or any other things you?
No, those were all the questions I got, and you dive deep into everything. So yeah, it was quite enlightening. If somebody wants to consult with you one-on-one, what is the procedure?
So you can go to my store, which is store.bodyrecomposition.com, and basically I've got the online consultation there. If you purchase a consultation, I've got an intake questionnaire. And if someone has a situation, and let me be clear, when you start getting into deep medical issues, it's not my area. Right? I know it's just, that's not something I can deal with, the dietary stuff, the exercise stuff. And so if I get a questionnaire from someone and I'm like, I'm not the right person to address this, I'll tell them that, and I'll obviously refund the money. But I have done at this point a number of consults that it actually, in one case, kind of going back to our early conversation. And I want to make one other comment. She's describing this to me, and she was relatively lean, but she tended to carry just more abdominal fat. She'd had menstrual cycle dysfunction from puberty, issues with fertility. And I'm like, have you ever been tested for PCOS? And she goes, no. I go, you really should. And she did, and I was right. It just, because again, she didn't have that significant cluster of damages. They were so mild in her, it never occurred to her, and it wouldn't have occurred to a physician. And which reminds me, I mentioned the birth control thing, and I mentioned early on that many women are not diagnosed either because it's just the doctors don't think to, but frequently they have something that is masking it. So I have a very good friend, and she hits menopause. She's about the same age as I am, and all of a sudden she gained like 45 kilos, like very, very, very rapidly, and went to the doctors. They couldn't figure out anything. Didn't know what was wrong, finally found a doctor who knew what she was doing and said, oh, we're going to test you immediately for PCOS. Now, what had happened, my friend had gone on birth control when she was like 15. It's very common in the US. It may, for all I know, it's common in the rest. I don't know what the rest of the world is like culturally, but just for unwanted pregnancies. She was on birth control from the time she was 15 till she hit menopause. She had PCOS but never knew it because the birth control was masking it. But as soon as she went off and the PCOS had the opportunity to sort of manifest itself, everything went wrong. And the physician basically treated her with everything we've talked about. So with consults, and with PCOS specifically, there's sort of this cluster. If someone tells me that from the time they hit puberty, they've always had a 45-day cycle, and I'm just going to be like, yeah, that's probably, I can't say that without it, will 100% be the case, but I think more often than not, it's probably that. So that's my consults. My books are available. And I talk about PCOS a lot in the women's book. Got a big old section on it. It is not, I'll be honest, it is not the easiest book to read. It is fairly technical so far as it goes. Just be forewarned. And then, all articles on my website, my Facebook group for women who want more information about this. We've got some really bright people, especially a number who really specialize in women's health, like at a medical level. They can cover issues I can't address. Because like I said, once you get out of a certain realm of, not my area, I'm not going to touch it. I don't feel comfortable with it. I would hate to give someone bad advice when they're dealing with certain, because I mean, a lot of this stuff is tough. The infertility stuff for women that really want to have children, that's brutal. And, fertility clinic stuff, not cheap, not easy, often doesn't take. I mean, I know it can be a tremendous amount of hardship on everybody involved. And, you see these numbers and you're like, with a 5% weight loss, 40% of women who became spontaneously pregnant, like 50% ovulation, menstruation improves. Like, that seems the easier initial route. Not that the medical treatment might not be necessary even after that, but if that alone can cause such a profound improvement in symptoms, to me, it's certainly worth pursuing that first. And that may be, that may be all that it takes.
And Lyle, one more question. On a scale of 1 to 10, how awesome is training Sumi?
Oh, it's a 10. It's very funny. When she first moved to Austin, which was 2010, and I first met her, and I this test I was playing around with, and I was just like, I told her, I'm like, you would be the perfect athlete. And now that I've been training her for, I guess we're going on 5 years now, I stand by that. She is dedicated, she's focused, she's intense, she does the work, and I want to make it clear that she's the one that said this, not me. This is not me being mean to her. She once said that we make the perfect team because I don't stop thinking and she doesn't think at all. And it's true, right? In that sense, like, not that she doesn't have the right to ask questions or ask me why, but basically she trusted me as a coach and she just does what she's told. And she doesn't think about it. She wants me to do all that. She doesn't want to do it. She just wants me to give her the work and give her the training and get her the medals. So yeah, she's a fantastic athlete. Have you had her on your podcast? Like,
yes, I have. Yeah.
She's awesome, and she's actually, whenever I talk, she has an understanding of many of these ethnic and cultural issues. I keep asking. I don't know, but she's the one who really made me very aware of some of these issues. And I'm sure she writes about that, and she's had a number of clients that are Indian. And she goes, yeah, just like we talked about, getting protein intake up can be very, very, very challenging. Getting dietary fat into moderate levels or healthier levels when ghee and butter and things like that are just such a standard part. So I'm from the southern U.S. and the southern United States. Everything, it's similar in a different way. All the foods are covered in batter and deep fried. Everything, enormous amounts of diet. It's the same thing. The diet is terrible. It's tons of meat, probably too much. And it's all charred, fatty, barbecued meat with tons of boiled fats, vegetables cooked until they're gray when we eat them at all. This is just gross. Everything has bacon in it in the South. Like they cook, it's called a ham hock. Like,
yes.
One of my very first girlfriends, she is vegetarian. Long before in the US it was common. This was the mid 90s. It was still a very new thing here. And we went to a non-vegetarian restaurant and she asked about some meal because, is this vegetarian? And the waitress said, well, it has bacon in it. And the girlfriend said, well, can you take that out? And the waitress said, it's only a little. That's the South, right? Like that's the Southern mentality. So it's very similar, but Simi has made me very well aware of that. And I know she's written a lot about that on her Facebook wall. And, there's other issues we're finding, without getting too far off topic, huge ethnic differences in disease incidence, Southeast Asians are more prone to diabetes, metabolic syndrome, higher body fat at any given BMI, et cetera, et cetera, et cetera. And like, so yeah, even outside of me training her, which is just the joy of my day, because she brings 100% every time. Even when it's not going fantastically, she never quits, and it's hard. You can't ask for more. But she's made me very well aware of a lot of socio-cultural and ethnic stuff that, as a dumb American, I just didn't know, including how to make sure and pronounce people's names correctly, because I didn't know. So,
well, Lyle, thank you so much for joining us today. And I'm sure a lot of people have gotten their answers, and they have some direction to begin working on their PCOS.
Very good. Certainly hope so.
And I hope for more podcasts with you in the future.
Please, absolutely. I'd love to be on again.
Yes. Thank you. You're going to say something, but you're going to say something right
now? No, I don't think so.
Oh, okay, fine.
I don't think I was.
All right. So you have a great day. Actually, it's night there, right?
Yeah.
Have a good night. It's 10 in the morning here.
Yeah, it's 10:30 here, so I guess we're 12 hours off exactly. So
yes. Awesome. Thank you so much.
Thank you so much.
Bye.